Hello, this is Patricia Steger. This is my high-risk infectious disease presentation on Middle East Respiratory Syndrome for the Principles of Epidemiology of Infectious Diseases course, MSI program, University of Providence. Early in the disease course, Middle East Respiratory Syndrome, also known as MERS, presents with fever, chills, and myalgia. This is followed within a few days by a non-productive cough and shortness of breath. Abdominal pain, diarrhea, and vomiting happens in approximately a quarter of cases. The illness progresses to pneumonia, showing decreased oxygenation and abnormal chest X-rays, leading ultimately to pulmonary failure in severe and fatal cases. Shock and renal failure are also commonly reported in severe and fatal cases. Laboratory abnormalities, including decreased platelets, decreased lymphocytes, and increased LDH, have been reported. MERS is caused by a coronavirus. This virus, known as MERS-CoV, is an enveloped positive-sense single-stranded RNA virus. The RNA encodes for 4 structural proteins, including spike, or S, membrane, or M, nucleocapsid, or N, and envelope, or E, as well as other proteins. The spike proteins on the surface of this virus particle appear as a crown, or corona in Latin, therefore giving it its name. Coronaviruses are known to infect animals and humans. Coronaviruses were first identified in animals in the 1930s. 30 years later, the first human coronaviruses were identified. MERS was identified as a novel coronavirus in 2012 and was first recognized as causing severe respiratory illnesses in the Kingdom of Saudi Arabia and Qatar. The only documented zoonotic source of MERS-CoV human infection has been the dromedary camel. Since the 1980s, evidence shows MERS-like coronaviruses circulating in camels. However, these were probably not human pathogens. Phylogenetic analysis has estimated the most recent common ancestor to MERS-CoV was in March 2012. Worldwide, bat species are known hosts for coronaviruses. Although MERS-CoV has not been isolated from bats, RNA segments have been identified in the Egyptian tomb bat in Saudi Arabia. Camels may have acquired the virus from bats in the distant past. As of November 2019, there have been 2,494 laboratory-confirmed cases and 858 deaths worldwide. The case fatality rate is 34.4%. MERS has been identified in 27 countries. However, the majority of cases and deaths have occurred in Saudi Arabia. Primary cases occur via contact with infected camels, their excretions, secretions, and products, including raw camel meat. The mechanism of transmission is droplet or direct contact. It is possible that transmission can occur through an indirect contact and fecal-oral routes. No vertical transmission has been identified. MERS has a 2 to 24-day incubation period with a 5-day median. Transmission to secondary cases appears to occur in the second week of illness when symptoms and viral loads peak. Cases of supershedding have been identified. Diagnostic testing for MERS is available only in public health laboratories. Due to possible false positive results, only patients with a high degree of suspicion should be tested. Molecular and serological methods are available. Serum samples are screened using enzyme-linked immunosorbent assay and, if positive, confirmed with microneutralization assay. Serological tests may exhibit cross-reactivity and false negative results. Reverse transcriptase PCR has high sensitivity and 100% specificity. Specimens from the upper and lower respiratory tracts should be submitted for analysis. Recovery is higher from lower respiratory specimens. MERS-CoV has been detected in stool specimens also. Current treatment strategy is supportive care. Admission to intensive care and mechanical ventilation are required for severe cases. There is little data on therapeutic regimens. Early treatment with antivirals may be effective. Mouse models have shown the effectiveness of human and camel convalescent sera containing antibodies. Hospitalized patients should be placed in an airborne infection isolation room. Also known as an AIIR, these are single-patient negative air pressure rooms with air exhaust through HEPA filters. If an AIIR is not available, the patient should wear a face mask and be placed in a treatment room with air exhaust through HEPA filters, maintaining the door closed. Patient care staff should be limited and a log kept of entries and exits. Isolation duration is on a case-by-case basis and requires input from local, state, and national health authorities. Healthcare providers must use airborne and contact precautions in addition to standard precautions when caring for a suspected or known MERS patient. Hand hygiene before and after patient contact, including before and after personal protective equipment use, or PPE, must be observed. Proper PPE and order of donning include a gown, a disposable N95 mask or reusable air-powered respirator, eye protection, and gloves. Great care should be taken when removing PPE after patient care to avoid exposure. Aerosol generating procedures should be performed only if absolutely necessary, preferably in an AIIR with only essential staff present. Healthcare workers caring for MERS patients are at a higher risk for exposure and illness. Between 2015 and 2017, there were 11 MERS healthcare outbreaks identified, with healthcare workers comprising 13 to 89% of cases. Healthcare worker cases have a lower median age and a higher proportion of females than non-healthcare worker cases. Healthcare worker exposures can be prevented by ensuring full comprehension of infection prevention measures, such as early recognition of respiratory symptoms requiring patient masking, prompt implementation of isolation precautions, and appropriate use of personal protective equipment by all staff and physicians. Clinical department workflows should be adapted to support early identification and isolation of suspect cases. Domesticated camels are used as transport, for hauling, for food products such as dairy and meat, as well as for their wool and hides. Camel workers have the highest level of exposure to camel body fluids, for example, nasal, oral secretions, and urine. One study found 50% seropositivity for MERS in camel workers with 0% in a control group. The authors hypothesize camel workers with subclinical or mild disease are an intermediary and can transmit MERS to others with no camel contacts. MERS-CoV's surface spike protein binds to epithelial cell receptors in humans and bats. Several structural proteins on the viral particle are involved in mechanisms that evade the host's innate immune system response. That is, the rapid recognition of foreign molecular structures by monocytes, macrophages, dendritic cells, and natural killer cells. This in turn delays the response of the adaptive immune system comprised of antibody-producing B cells and cytotoxic T cells. Due to S protein's role in infection and pathogenesis, it serves as a good target for vaccine development. S protein has been found to induce a strong antibody response in animals. As of yet, there are no MERS vaccine approved for humans, although 2 S-based vaccines are scheduled for clinical trials. Nanobodies are single-domain antibodies obtained from camelids and sharks. Researchers have developed a novel MERS nanobody which targets the S protein. These can be produced in large quantities in yeast and have proved to be prophylactically and therapeutically effective in human-like mouse models, undergoing a lethal MERS-CoV challenge. In the diagram, the red nanobodies bind to specific viral sites to block binding with DPP4 receptors, thus blocking the virus's initial mechanisms to infect cells.